Look, kid. Bad things happen, and you can't do anything about it, right?
Right.
Wrong! When the world turns its back on you, you turn your back on the world.
Well, that's not what I was told.
Then maybe you need a new lesson. Repeat after me. Hakuna Matata.
What?
Hakuna Matata. It means no worries.
Repeat after me. Hakuna Matata.
Hakuna Matata. It means no worries.
Las exigencias de la vida actual nos empujan más y más a concentrarnos en el trabajo, en el rendimiento, en el éxito y en ganar. Pero el costo ha sido perder contacto con la familia, los seres queridos, los amigos y hasta con nosotros mismos. Gracias a la ciencia sabemos que desde que uno nace, e incluso desde antes, las relaciones afectivas son fundamentales para desarrollarnos. Nuestros vínculos con las personas que nos cuidaron en la primera infancia tienen un impacto importante en cómo nos formamos como personas y también en nuestras futuras capacidades para enfrentar la vida y relacionarnos con los demás. Al crecer, tenemos dos tareas importantísimas. Por un lado, formarnos y reconocernos como personas únicas para así diferenciarnos y definirnos con respecto a los otros, saber quiénes somos. Por otro lado, nuestra condición humana nos lleva a necesitar permanentemente de otras personas, a conectarnos, a querer y a dejarnos querer. Para que nuestra mente y cerebro se desarrollen, necesitamos entonces de los otros, una red de afectos que nos sostenga durante la vida, tal como los elementos de la naturaleza se mantienen en equilibrio unos con otros gracias a los nexos que hay entre ellos. Las relaciones de afecto con otras personas son entonces fundamentales para nuestra vida, desde la primera infancia hasta la vejez. Y la ciencia ha mostrado que incluso llegan a ser el factor de protección más importante para nuestra salud física y mental. Por ejemplo, sentirnos parte de un curso o de un grupo de trabajo, de un equipo deportivo o de una banda musical, entrar a un club o participar en actividades vecinales, una vida de pareja, de amistad, en familia, o compartir con los niños y niñas previene que nos enfermemos o que caigamos en el desánimo o la ansiedad. Más aún, así como la conexión amorosa entre las personas es vital para cuidar la salud, la ciencia ha demostrado que nuestro bienestar depende también de que podamos prestar atención a las situaciones que experimentamos en el presente, que aprendamos a darnos cuenta de nuestras percepciones, pensamientos y emociones, que las aceptemos en un acto de amabilidad con nosotros mismos. Tener un propósito, saber qué queremos para nuestra vida, es clave para nuestra salud mental. Y si nos vinculamos con los otros en este camino, nuestra vida tiene un sentido más natural, más completo, y todos ganamos como personas. Cuidemos nuestra salud mental. Hagamos una pausa de tiempo en tiempo. Revisemos nuestros vínculos, nuestra necesidad de apoyo y afecto, y también la de los otros. Conectémonos con los demás y querámonos a nosotros mismos también.
Good morning, everyone. It's lovely to see you back in our second day of our third Latin American summer school for research in depression and personality. We have a busy day ahead of us with lectures, workshops, student presentations. So I'm looking forward to productive discussions, and we're gonna start our day with a really interesting presentation. And it's my real pleasure to introduce my dear colleague, Jaime Delgadillo, who is joining us from the University of Sheffield in the UK. We haven't seen each other in a while, but he's one of the people you saw wearing funny glasses in my presentation yesterday when we were looking at the solar eclipse in Chile. Seems like ages ago. So it's really nice to see you, Jaime. We've seen each other a little bit over Zoom, working in some projects, but this is really lovely. So I will introduce Jaime, who is going to deliver a lecture entitled Psychological Treatment Selection for Patients with Different Phenotypes of Depression and Anxiety. Jaime is a psychologist. He has a PhD in health sciences research, and he's the director and senior lecturer of the clinical psychology unit at the Department of Psychology at the Faculty of Science at the University of Sheffield. He's also director of research in psychological therapies, Rotherham, Doncaster, and Southampton NHS Foundation Trust. And he's been looking at really interesting data sets for a while that stem from an IAPT NHS project. So it's really, really lovely data that we're always able to look at when Jaime joins us. And he is also part of our international network for the study of depression heterogeneity. So Jaime, welcome. It's really nice to have you here with us.
Thank you very much for the invitation to participate in this excellent initiative. Thank you very much to Dr. Alex Ben for including us and for the very productive collaborations that we have over the years. I'm Jaime Delgadillo. I am a senior lecturer in clinical psychology at the University of Sheffield in the United Kingdom. In this talk, I will be focusing on one central idea, which is that in any large clinical sample of patients with mental health problems, even if those patients have similar symptoms, for example, if they all present with depression or anxiety-related problems, there are other aspects of their features and life contexts that make them quite different to each other. In the field of digital diagnostics, which is an emerging field in healthcare today, the expression phenotypes refers to people with different features who may form part of subgroups of the larger clinical population and who may have a different response to treatments available in healthcare systems. So the central idea here is that even if patients have similar symptoms, they may be quite significantly different in other features and in their treatment response. To unpack that idea and discuss it, I will be presenting data from two linked studies. One observational study where we attempted to identify specific phenotypes of patients with depression and anxiety, and a more recently concluded clinical trial where we used this information to investigate if matching patients to treatments based on understanding of underlying phenotypes may make a difference to clinical outcomes. So before discussing the specific studies, I will provide some background information about the context where we do our clinical and research work in the United Kingdom. As you may know, in the United Kingdom, clinical guidelines for the treatment of common mental health problems recommend that psychological interventions should be organized in a stepped care model. A stepped care model includes various evidence-based treatments that are organized in different levels of intensity. Typically, most patients with common mental health problems initially access brief, low cost and low intensity interventions that are referred to as low intensity treatments. And these are based on principles of cognitive behavioral therapy. They usually last somewhere around 6 to 8 sessions, and they are guided by a professional psychological well-being practitioner. You can think of this particular profession as a coach that supports people to learn and implement coping strategies informed by CBT principles. Those patients who don't fully benefit from these low intensity self-help oriented interventions later have access to more intensive and expensive psychotherapeutic interventions. So these may include various traditional forms of psychological treatment, for example, cognitive behavioral therapy, person-centered experiential therapy for depression, interpersonal psychotherapy, and other psychotherapeutic approaches. Literature in the field tells us that organizing these interventions in a stepped care model leads to improved effect sizes, clinical effect sizes, and the probability of recovering from common mental health problems, at least by comparison to control groups such as usual care or waitlist controls. These effect sizes are somewhere in the small to medium range. For example, expressed in Cohen-D scale, meta-analyses indicate that there's a 0.34 or small to moderate effect size advantage of stepped care interventions. So there is good data that organizing interventions in a stepped care model can be an efficient and effective way to deliver psychological interventions. In theory, it's referred to as a self-correcting model, where patients eventually receive the treatment that meets their needs. But in my opinion, this self-correcting expression is perhaps an elegant way to refer to a trial and error system, where actually we're not entirely sure whether these low-intensity interventions, the first step in the system, may be enough to meet patients' needs, but there's a bit of a trial that happens, and if that doesn't work, people eventually get stepped up to more intensive interventions. So it is a trial and error system. In practice, recent studies collecting data from stepped care services have started to identify that some patients with specific features respond less well to these interventions, and particularly low intensity interventions. Some examples of these features may be severe symptomology, severe depression symptoms, for example, and the comorbidity of other health problems such as chronic illnesses, including heart disease or chronic pain or diabetes or other comorbidities. It's also been shown in a number of studies that patients that have personality disorder traits seem to respond less well to brief time-limited interventions. And in addition, patients who live in socioeconomically disadvantaged circumstances also seem to be less likely to recover from mental health problems in this particular stepped care setting, particularly those who are unemployed and who may be also affected by economic or financial hardship, or those who may be living in neighborhoods that have high crime rates or low income. So in summary, not all patients respond in the same way to these stepped care interventions, and patients with certain features appear to respond less well than others. And logically, patients with a combination of 1, 2, or more of these features perhaps have a bigger disadvantage in terms of responding well to these interventions. So this brings us to the concept of complexity, complex cases, and stratified care as an alternative way to organize psychological interventions. Stratified care is an approach that is influenced by concepts in the field of precision and personalized medicine, also referred to as stratified medicine. The basic idea here is that instead of offering everyone the same initial step of treatment and then moving people to other steps of treatment if they don't benefit from the initial intervention, stratified care aims to match patients to treatments in a strategic way in order to maximize the potential benefits of available treatments in any given system. And the particular rationale for treatment matching is based on the notion of prognosis. So according to the stratified medicine concept, even if all patients in a particular setting have similar symptoms. So for example, let's say that in this slide, we have a representation of a large clinical sample of patients, all of whom may meet diagnostic criteria for major depressive disorder. So even if all of these patients have something in common, they may be quite different to each other in other respects, in such a way that some patients have an excellent prognosis. They're likely to respond very well to treatment in a few sessions with lasting effects. But on the other side of the spectrum, other patients with the same diagnosis may not respond to treatment at all. They may in fact deteriorate during treatment, or treatment progress may be much slower. So according to stratified medicine, patients lie on a continuum of complexity, where some patients have more complicated clinical, demographic, and life circumstances that make it more difficult to achieve a good therapy outcome with standard interventions. And therefore, the rationale of stratified medicine is to match the level of complexity of patients' features and presentation to the level of intensity of available treatments. So more complex patients who have features that are statistically associated with poor treatment response would be fast-tracked to more intensive and expensive treatments, in a way trying to match the level of need with the intensity and length of treatment. That's the basic premise of stratified care. That, of course, naturally raises the question, well, in the context of primary care psychological services, how do we differentiate between complex cases and less complex cases? What are the features that might help us to draw these distinctions? And now I'm alluding to this broader concept of phenotyping, of identifying subgroups of the population who have shared features or similarities that mean that they may have also potentially similar prognosis. So this brings me to the first study that I will discuss, which was published a few years ago in 2017, published in the Journal of Consulting and Clinical Psychology. This was a retrospective analysis of routine practice data collected from stepped care services in the north of England. So it's an observational and retrospective analysis. We collected data for 1,512 patients treated in the Improving Access to Psychological Therapies program in the United Kingdom, which is a stepped care system of psychological treatment delivery. All of the patients had finished their treatment episode at the time when we collected data. And we wanted to identify what are the features, the characteristics of those patients who had a good outcome defined by reliable and clinically significant improvement in depression and anxiety scales that are routinely collected in these services. So the outcome measures that were available to us in this data set were the PHQ-9 measure for depression symptoms and the GAD-7 measure for anxiety symptoms. The key question was, can we identify patients that have a much higher probability of a poor treatment response, and what are their features? Is it possible to distinguish between a phenotype of more complex and less complex patients? In order to approach this, we split this data set into two halves. One half of the data set was referred to as a training sample, and the other half of the data set was referred to as a testing or cross-validation sample. The idea being that we use the first sample, the training sample, to discover patterns in the data, to identify which features, which characteristics of this patient sample might be statistically associated with poor treatment response. In this case, defined as patients who finish their treatment episodes with ongoing clinical level depression and anxiety symptoms. So we might refer to these as unresolved or ongoing chronic symptoms that were not alleviated through the episode of care. We were particularly interested in understanding which patients are more likely to have that poor outcome. And in order to discover features, we used a particular methodological approach, a machine learning approach called lasso with optimal scaling. The lasso is a particular form of regression. It's referred to as a regularized regression approach that enables us to achieve two goals. The first goal is variable selection. So you might start with several features, demographic and clinical features for all of your patients. And variable selection enables you to identify and only retain the features that are most reliably associated with the outcome of interest. So that's variable selection. You might start with several features and it reduces the data set to the features that matter most to predict this particular outcome. And the other task or goal that is achieved through this machine learning approach is weight setting. What that means is that of the possible features that predict poor treatment outcomes, we expect that some features will be more important than others. Some features may be especially strong predictors of poor treatment response, whereas other features may have, let's say, weak associations, but statistically significant associations nevertheless. So this machine learning approach enables us to do those two things, to achieve variable selection and weight setting. So these are the results. The features that were significantly associated with poor treatment response are listed on the right side of this slide. So people who were unemployed were less likely to recover from their symptoms at the end of treatment. People who self-reported being from a racial or ethnic minority also seemed to have a lower probability of recovery compared to people in the majority white British population. Younger patients, particularly teenagers, were less likely to recover from their symptoms. And we found that that was likely to be explained by dropout. It seems that young people, from a probabilistic perspective, are more likely to drop out compared to older people. And therefore, you might assume that many of them don't receive an adequate dose of treatment or a long enough intervention to lead to maximum benefit. Furthermore, as you might expect, higher baseline severity of depression measured by the PHQ-9, anxiety measured by the GAT-7, and functional impairment measured by the work and social adjustment were also significant and also particularly strong indicators of poor prognosis. Furthermore, this was especially interesting because we identified a series of personality traits that were associated with poor treatment response. And this was the final selected set of personality traits from a wider pool of personality traits that we collected in this sample. Of all of the personality traits available to us, these were the most reliable predictors of poor treatment response. So they are interpersonal avoidance, interpersonal suspiciousness, impulsivity, and interpersonal dependence. In summary, you can see that it's not just the clinical or symptomatic features that matter, baseline severity, but also socioeconomic and demographic features, as well as personality traits, make a difference to how people use services, engage with the therapy process, and ultimately how they respond to treatment. Now, we found that all of these variables predicted poor treatment outcomes in the first half of the data set in the training sample. And we were also able to demonstrate that using these features enables you to predict which patients will have a poor treatment outcome with reasonable accuracy in the independent test data set. So this gives us some more confidence that this particular model of phenotyping is likely to generalize to new samples, since it enabled us to identify with some accuracy patients with a poor treatment response in a statistically independent sample. Now, that gives us some confidence in terms of statistical modeling and the discovery of patterns in the data that replicate in another data set. But another question is, well, what do we do with this information? If these indicators predict poor treatment response, what should we do about people who have one or more of these indicators? What kind of treatment might be better to prevent poor treatment outcomes or to improve their health outcomes? The evidence from this observational study suggested that a stratified approach to treatment selection could potentially be a way of improving treatment outcomes in this clinical population. In other words, those patients with the features listed on the right side of the graph, especially people with a combination of these features, are perhaps more likely to benefit from high-intensity treatments rather than low-intensity treatments. And again, this is influenced by principles of stratified medicine, where you would match the level of intensity to the level of complexity in order to maximize expected benefit. So in order to test this hypothesis in a prospective design, this led us to our next study, which was more recently concluded. We started this trial in 2018, and we recently finished the analysis of primary outcomes and also a cost-effectiveness economic analysis. This trial will be appearing in JAMA Psychiatry next month. It was recently accepted for publication, and you will be some of the first to hear about the results. So let me describe the design of this trial. What we wanted to achieve is, in a randomized experiment, in a randomized control trial, to test what would happen if some patients from a clinical sample of people with depression and anxiety are matched to treatments using a stratified care approach by comparison to what happens already in usual practice in the United Kingdom, which I described earlier, which is a stepped care approach to treatment selection. Based on prior evidence from the observational study that I described, we expected that we may have more people recovering from their mental health problems, particularly from depression symptoms, because that's what the observational study seemed to indicate. However, there are many uncertainties and limitations of drawing conclusions from non-experimental observational studies, and therefore this was a strong way to test the hypothesis, a more methodologically rigorous way to test it. So the main question we wanted to investigate was the following: does stratified care work better than stepped care? Does it lead to better outcomes? To answer that question, we designed a pragmatic multi-site, because it included several psychological services, 4 services in total. And it was a cluster randomized control trial where randomization was done at the level of individual clinicians. So rather than randomizing individual patients, we randomized therapists, participating therapists, to either a stratified care treatment assignment or a stepped care control group. I'll explain how this worked in the next few minutes. And the primary outcome for this trial was the number of patients, or the proportion of patients meeting criteria for reliable and clinically significant improvement in the PHQ-9 depression scale after treatment. And this is a strict definition that requires patients not only to have reduced overall level of symptoms, but it requires symptoms to be in the subclinical range and to have improved by a minimum of 6 points on the PHQ-9 scale, so that we can be confident that any improvements are not simply explained by measurement error. And therefore, the strict definition enabled us to get a sense of whether a remission, a full remission of symptoms could be improved through stratified care. We also expected that the main effect would be observed in depression symptoms rather than anxiety symptoms, since our previous work indicated that stratified care seemed most promising, particularly with depression symptoms. We pre-registered our statistical analysis plan before recruiting participants, and the pre-registered plan is available online. Finally, we compared the proportion of patients with full remission of depression symptoms between groups using logistic regression, controlling for baseline severity. Now, what happened in the trial? In the previous observational study, we identified several features, demographic, symptomatic, and personality features that seem to influence people's prognosis. Based on that evidence, we developed a computerized app that enabled clinicians in the trial to identify complex cases by collecting information about those specific features that we identified in the previous study. So in the new trial, clinicians that were doing initial assessments with patients presenting to the stepped care services for treatment of common mental health problems, they conducted semi-structured interviews using exactly the same framework. So therapists in the intervention and the control group asked the same questions. Now, in this slide, you have a short animation that shows you what that interview schedule looks like. So there's some demographic features related to age, ethnicity, employment status. There's a personality trait questionnaire, which is a validated short screening questionnaire for personality disorders. We also collected information about baseline symptom severity on depression, anxiety, and functional impairment, and we collected information about diagnoses. In the experimental group, once therapists input intervention into this app, they received an automated treatment recommendation like the one you just saw on screen. So that treatment recommendation might say, we recommend high intensity treatments, as in the example you can see on screen, or it might say we recommend low intensity treatments. So therapists assigned to the stratified care group received an automated recommendation, and they were trained to discuss that recommendation with patients on the telephone at that initial assessment appointment. And later they had to confirm which treatment pathway was selected for that patient, expecting that the therapists in the intervention group, in the stratified care group, may well go along with the recommendation from this computerized application, but there may be other reasons to not go along with that recommendation, for example, including patients' preferences. And therefore, we collected information about compliance or adherence to this particular approach. Now, what's really interesting is that in both groups, in the stepped care and in the stratified care groups, all of the clinicians involved in the trial collected exactly the same information, except that in the stratified care group, the clinicians received this automatic treatment recommendation, which was output by a machine learning algorithm we have trained from the previous study. So after those assessment interviews, patients were assigned to treatment in the stratified care group. Those recommendations were influenced by this app, the automated clinical recommendation. The rationale behind this algorithm is to match complex cases to high intensity treatments and less complex cases to low intensity treatments. In the control group, patients were allocated to treatment in the usual way following stepped care guidelines. Here's a consort diagram that describes the flow of participants through the various phases of the clinical trial. Some summary points are that overall, 1,453 patients were screened for eligibility. Not all of them were eligible for treatment in this particular setting because not all of them had common mental health problems. So, for example, some patients' primary reason for seeking help may have been an addiction problem. They were therefore signposted to addiction treatment services, or patients who had severe and enduring mental health problems like psychosis or bipolar disorder were also referred to other services that treat those particular conditions. Overall, 951 patients were eligible for treatment in this stepped care system and were included in the trial. And that was higher than our recruitment target of 760 to meet the minimum sample size to conduct the intended statistical analysis. Overall, 30 clinicians were involved in the study, and they were randomized 15 to each of the groups. So 15 were randomized to stratified care, 15 were randomized to stepped care. This table gives you a summary of the clinical and demographic features of the patient sample included in the trial. So some summary points: the mean age was around 38 years of age. More than half of participants were females, 65%. The majority, 95%, were of a white British background. About close to 20% were unemployed. You can see the prevalence of specific presenting problems in the next section. So at least half were presenting for an affective disorder. That includes major depressive disorder and recurrent depression, also dysthymia. And towards the bottom of the graph, you can see the baseline severity for depression, anxiety, and functional impairment. Overall, these indicators are quite similar to trends from national data. So we are reasonably confident that this is a fairly representative sample of this stepped care treatment system. Okay, so these are the main results, the primary outcome. In this graph, you can see a comparison of the percentage of people with full remission of depression symptoms at the end of their treatment pathway, otherwise referred to as reliable and clinically significant improvement. In the stratified care group, 52.3% met criteria for RCSI, or remission of depression symptoms, by comparison to 45% in the control group, which is the usual stepped care treatment selection approach. These differences were statistically significant after controlling for baseline severity, which conforms to our pre-registered primary analysis. However, as expected, the differences were not statistically significant for the GAD-7 anxiety measure, and I will comment on this in the next few minutes. So this supported our primary hypothesis that applying stratified care by matching patients to treatments according to their phenotype may potentially improve clinical outcomes. This is a graph from secondary exploratory analyses where we repeated these comparisons of remission of depression symptoms in two distinct phenotypes. So the first phenotype is referred to as complex cases, those patients with a combination of the features that we were discussing earlier, a combination of demographic, clinical, and personality features. And on the left side is the standard cases phenotype, so people who don't meet the criteria for a complex combination of clinical, demographic, and personality traits. If you look at the complex phenotype or subgroup, you can see that there is a trend towards a higher remission of depression symptoms in patients who were treated using the stepped care approach, the stratified care approach. However, this difference was not statistically significant. And this was contrary to our expectations and hypotheses. So we expected that complex cases would have better treatment outcomes if they were matched to high-intensity treatments from the start of their pathway. The numbers seem to support that expectation, but this is not statistically significant. On the contrary, on the other phenotype, the standard cases phenotype, there is quite a large, a 10% difference in depression remission rates, and that is statistically significant. So this was surprising when we first did this analysis, because it didn't conform to our prior expectations. And that might be because the perspective we were taking before doing this trial was that matching the more complex cases to more intensive interventions might lead to better outcomes for them. It looks like actually diverting complex cases away from low intensity treatments seems to make a big impact at a system level. In other words, more of these standard cases, the ones with less complicated clinical personality and demographic features, most of these start their treatment pathway with a low intensity treatment. And it looks like the stratified care matching approach actually optimizes the suitability of patients for those low intensity treatments, leading to quite impressive results in that specific phenotype. So it's quite an interesting and surprising finding. Moving on, this is a summary of the differences in treatment pathway between stratified care and stepped care. And also it summarizes some of the economic analyses. So let me talk you through this. The triangle shape represents this stepped care or tiered system where you have low intensity interventions and high intensity interventions. If you look to the right side of the graph in stepped care, which is the usual way of organizing these interventions in the UK, you can see that the majority of patients, around 78.5%, were initially assigned to a low intensity treatment. And that's as we would expect. The majority start at that step of care. And only a minority of patients, around 21% or so, were initially allocated to high intensity treatments. Now, why does that happen in stepped care? There are some conditions, for example, post-traumatic stress disorder, social anxiety disorder, where only high-intensity psychotherapies are recommended. And therefore, in stepped care, some cases, for example, those with PTSD, are directly allocated to high-intensity treatments. Now, if you look to the left side of the graph, this describes the pathway for stratified care. You can see that it's a split of about half and half. Half of patients are allocated to start with a low-intensity treatment, and about half of patients are fast-tracked to a high-intensity treatment from the start of their treatment pathway. So the way in which patients flow through a treatment system is remarkably different between stratified care and stepped care. In summary, in stratified care, many more people access high-intensity psychotherapies. That's the main difference. For that reason, you would expect that there's a cost difference. So the average treatment cost in the usual stepped care pathway was around £146, whereas in stratified care, the average treatment cost was higher at £248 on average. If you take the difference between those, the cost difference is approximately £95 on average. Considering the overall cost of episodes of care, you could argue that that is a relatively modest incremental cost, particularly because stratified care leads to a higher probability of depression improvement. So approximately 7 to 8% higher probability of improvement of depression applying stratified care. In that sense, it could be argued that for a small incremental cost in the overall cost of care, you also get more effectiveness for that cost investment. So just to finish with some summary points of the key findings, this stratified care approach, which is a personalized treatment matching approach, resulted in better depression treatment outcomes in the full sample, approximately 7 to 8% higher depression remission rates, but not for anxiety. And that's probably explained by what you can see in the previous graph. So in stepped care, some patients get fast-tracked to high intensity anyway, and this is most often those with anxiety-related problems, like PTSD, social anxiety disorder, body dysmorphic disorder. They tend to be fast-tracked to high intensity. In that sense, the pathway for those patients is not very different between stepped care and stratified care. And we think that that may be the most plausible explanation for the lack of significant differences for anxiety symptoms specifically. Furthermore, stratified care improves clinical outcomes at a modest incremental cost of around £95 per average treatment episode. And this results in a higher percentage of people accessing high-intensity treatments, which explains that cost difference. There are, like in any other study, of course, some key limitations. Especially important limitations in this study are a lack of longer-term follow-up. So all of these results are, we can only draw conclusions in the short term at the end of people's acute phase treatment, but we simply were unable to collect longer-term follow-up data, and we therefore can make no conclusions about long-term sustainability of these differential treatment responses between pathways. Furthermore, although we were able to compare the overall costs of treatment between these treatment pathways, the economic analysis was limited to comparing treatment costs, but we did not collect other economic indicators, such as quality of life measures that could enable us to do an analysis of quality adjusted life years or service utilization after completing these treatment pathways. So there are some important limitations that we would seek to explore and improve upon in future studies. So to finish, hopefully with plenty of time for discussion and questions, this study and other studies emerging in this new and exciting area of precision mental health care tell us that the collection of routine data in psychological services at a large scale, otherwise referred to as big data, combined with the utilization of modern statistical approaches related to machine learning and cooperation with industry partners in order to develop artificial intelligence technologies that help us to make decisions in clinical care, can be a promising way to improve clinical outcomes in the future. This series of studies demonstrates something that in the field is referred to as decision support tools. Tools that are developed through observation of patterns in clinical data and that can help psychological therapists and health services to make data-informed or evidence-based decisions. So I'll finish my talk there and invite you to make any comments or questions. I think hopefully we have plenty of time for that now.
Thank you very much.
Repeat after me. Hakuna Matata.
Hakuna Matata. It means no worries.